are.
I just feel like recording is starting.
Gosh, there's some background noise. So if I could ask all of you to mute yourself if you're not speaking. And welcome everyone. Good morning, good afternoon, good evening, wherever you are. This is the March Fresh School Health and Nutrition monthly webinar. My name is Mohini Venkatesh, and today's webinar is on oral health promotion in school settings, a bit about the Fresh School Health and Nutrition webinar series, a series of presentations by leading policymakers, researchers, and implementers engaged in improving children across the world. Today we have three presenters, two of whom are with us at this hour. Dr. Bella Monse and Denise Duijster. I hope I got your name right, Denise.
It's Duijster. It's difficult, don't worry.
And Bella will be presenting first. And allow me to introduce Bella. Bella is well known in the school health and nutrition community. She works with GIZ as a global advisor on the Fit for School program based in Manila, supporting the regional program there, as well as spending part of her time in Germany and supporting the other programs. Bella is a dentist by profession. And our other speaker, Denise Duijster, is a researcher on social dentistry at the University of Amsterdam in Netherlands. She has a background in dental public health and has been involved in research around the Fit for School program in Southeast Asia. Welcome, Bella and Denise, and it's over to you.
Yes, thank you, Mohini, for your very nice and friendly introduction. I will speak first a little bit about the basics of oral health, and Denise will follow with showing some results of a school-based program, of the school-based program component of the Fit for School approach. Please, the next slide. Yeah, so as I said, I will speak about the basics of oral health. Next slide. As you might know, oral diseases have been mentioned by Margaret Chan as a neglected area of international health, and we all know that we have the tools and best practice to address them, but we need to ensure that they are applied and implemented, and that seems it's not really the case. Next slide. There's a very, very important sentence for the oral health community. Now we test our knowledge briefly. What do you think? What does prevalence of untreated tooth decay rank among the 291 diseases? Next slide. It ranks first. And we do the next slide. Click again. What do you think? Yeah, what do you think? How many people suffer from untreated tooth decay? Next slide. See it? What do you think? This is 3 billion people. It's near to half of the world's population suffer from untreated tooth decay, which means not those who have access to dentistry and have no tooth decay. They are not included in that. So here you see on a slide the estimated number of people affected by common diseases, and it's overwhelming to see that dental caries in primary and permanent teeth is really the bulk of diseases is there. Next slide. And we can really speak of a global epidemic. When we see about oral health, just for the knowledge of everyone, we have 3 different diseases. We have tooth decay, we have periodontal disease, we have the disease of having no teeth anymore, and we have oral cancers. What we speak about today and what is important for children is tooth decay. Next slide. So what is common, and this is a slide or a picture done in the Philippines. So it's very clear tooth decay is the most common disease for children worldwide on the planet. It's a multifactorial disease with a very, very strong social gradient, and you find more disease in lower social class. It has normally a very early onset. It starts early, and it will continue throughout life with lifelong problems and cumulative effects. What are the main effects? The main effects of untreated caries are pain, eating and sleeping impacts, poor growth development, low school performance, and what is very important to mention is that that disease is largely preventable by oral hygiene, by healthy nutrition, and and you need to have fluoride around. Next slide, please. Look at the cause of disease. There is, of course, something happening in the mouth. In the mouth, you need to have food. You need to have food which has sugar or will be metabolized to sugar, and you need bacteria. The bacteria are always there. You have a dental plaque, a biofilm, and together with the sugar, it produces an acid. This acid will start a process of demineralization within the mouth, and then there will be other phases of remineralization. It's always demineralization and remineralization, but if the process of demineralization is too long and you have too many episodes of demineralization and there's no time for the teeth to remineralize, you will have tooth decay. Of course, that doesn't happen and doesn't fall from heaven. It's something you will have that in a social system, in a family, where you clearly say, well, that's a family, that's in a person, but also in a family where healthy or unhealthy food is not available all the time, where there is a lot of sugar-sweetened beverages, where children do not brush their teeth regular. And this is, of course, also something which happens in a certain wider community outside the family. And this is also something which normally goes over the entire life. Next slide. Very important is to say, well, the basic global prevalence data for 12-year-olds, which is available, is very, very largely outdated, or many countries have only or have no data really available. Important, 1/3 of countries in the globe do not have any data. And next slide. Now we can see the tooth decay worldwide. You can see that it's really a difference between countries. You can see that in Africa you have either no data or lower caries levels, which has to do with less access to, or not enough money for the people to buy constantly sweets or sugar-sweetened beverages or junk food. And you see countries specifically in Southeast Asia, where we work, you see very, very high caries levels. You see also in South America, and you see them also in the Middle East. Next slide. Well, when we think we just need enough dentists and the problem will be solved, you can see that that is absolutely not true. You can see for Africa, you have very, very few dentists. So you have some countries in Africa with only 1 dentist per 200,000 people, where Europe and North America, Brazil, have something like one dentist to 1 or 3,000 population. So it's not the question of the amount of dentists, because we can clearly see that even all armadas of dentists could never treat the disease which is there. Next slide. Because majority of world's caries remains untreated, these are the figures for 12-year-olds. The dentists always work with decayed, mist, and filled. So you see the red is the decayed and the untreated decayed. You see mist is blue and the filled is green. And you can see that even in high-income countries, it's the first line, it's the HIC, stands for high-income countries. Half of the disease is untreated. The majority of tooth decay is really with the with the middle-income countries, and low-income countries have the lowest caries levels, but it's nearly all untreated. That's to be seen. And I think important to mention, even high-income countries, half of the disease is untreated. Next slide. Now we come to just figures that you get an idea. The reality in the Philippines, nearly all 6-year-old children, when they enter school, they already have dental decay, or tooth decay, an average 8 decayed teeth, and almost none of the caries is treated. It's nearly all untreated. Next slide. Yeah, and what is more important, or what is even adding to the pain and suffer, is that 82% of these kids have at least one tooth with severe infection. This is called PUFA. It's either an open pulp, an ulceration, a fistula, or an abscess. That's an infection in the mouth, and that's a very, very high percentage of children are affected by this, and this will always cause pain and suffer. Next slide. These are now figures, just the Philippines is not alone with this situation. These are figures from Cambodia, Indonesia, and Laos PDR, where we also did quite big surveys, and you can see that tooth decay and nutritional status is somehow linked. In all the countries, we can see that the children which are categorized as thin have the highest caries levels compared to those which are normal or overweight. Important here to see the high figure in Cambodia. The underweight kids have 11.7 decayed teeth in their mouth. So that just to give you an idea, more than half of their teeth already decayed. Next slide. So if there is that disease burden, why is it not a priority? What is interesting to see here is that the priority and where the money is going is still very much with infectious diseases. You can see here from this slide, you see the disease burden on the right side. You see this big red this big red chunk, which are the NCDs, and we can already say NCD stands for non-communicable disease, and dental caries belongs to the non-communicable diseases, and it is clearly the bulk of the disease burden. While when you look at the development assistance for health, you can see that the majority is still with HIV/AIDS, tuberculosis, malaria programs, which shows that this is still addressing infectious diseases. And also it's the point that it's quite difficult to address non-communicable diseases. Most of them are due to behavior, and it's very difficult to address it. It's not just something where you can give a pill. It needs behavior change programs. Next slide. So the non-communicable diseases are diseases which share common risk factors and which are diseases seen and categorized as diseases of a certain behavior. Well, why it's not a priority? We said that already. It's the top priority is still with the killer diseases, diarrhea, pneumonia, the huge amount of kids worldwide which are underweight, the children with worms, those infected by HIV/AIDS, and malaria. But we all know that obesity and cardiovascular diseases, these are non-communicable diseases, are on the rise, and these will become a bigger and more obvious problems in the next years. Next slide, please. Yeah, what is WHO doing? Are there any concepts what to do with the situation? WHO in 2002 has published a so-called basic package of oral care, and this basic package should provide, it's a policy document, a direction, should provide access to oral urgent treatment, which means countries should access to pain relief. That should be the highest priority. It should provide access to affordable fluoride toothpaste, because one knows that inavailability of it will reduce the caries levels. And it should provide treatment, so-called atraumatic treatment, which is something, it's a technique not using drills and not using electricity or running water, which can be used everywhere regardless of the circumstances you work in. That's a very nice concept. Unfortunately, this concept specifically of the atraumatic restorative treatment, even it's nice, it works, but it has never really been scaled up because it's still too expensive and too it needs too much resources. Next slide. Yes. So the access to oral healthcare is a big problem, as we have discussed before, and there are many, many people who really suffer tooth decay, and the very often only option for them is to look for pain relief and using illegal oral care, because many people in the world do not have access to care. And that's a very serious problem that affects children and adults, children as well, in the same way. We have done surveys and research to find out that between 15 and 20% of children in school were saying that they are suffering from toothache. Next, at the moment, in that moment when we put the question. So this is something that's very, very prevalent. Next slide. So there should be, as we said before, priority for prevention, because the disease to treat them is very expensive and there are no resources available, or very limited resources, or only in big cities. And treatment is in a way useless if you do not treat or address the root cause. And as we said, the root cause is the diet, access to fluoride, and the regular self-care and lack of regular self-care is the priority to look at. So prevention and self-care is the only realistic way for populations in low and middle income countries to improve oral health. Next slide. There has been a quite big conference in 2006 about the use of fluoride, and there's a very, very important statement saying prevention by daily use of fluoride is the only realistic way of reducing the high burden of tooth decay in populations. This came from WHO, from the World Dental Federation, and from the International Association of Dental Research. And this statement should be really used again and again, because that has to be memorized. That's the only realistic way. There are also other ways, but they're not realistic to reduce the high burden on a population level. Next slide. Well, what are the fluoride vehicles we have? We have toothpaste, we have water fluoridation, salt fluoridation, milk fluoridation. Next slide. Unfortunately, when we see that all, only 30% of world population has access to fluoride, most of them through toothpaste. Water fluoridation has problems as you need a centralized water system. Salt and milk only reach quite limited number of people. Next slide. So the most widespread is fluoride toothpaste. Fluoride toothpaste has already solid and long evidence, very, very good studies and good cost effectiveness, and it's something which you can use your entire life, and you have the fluoride where you need it, you brush and you spit it out. But in some areas of the world, it's not it's not affordable, or very often the quality control is a problem, because if the fluoride in the toothpaste is not in or doesn't have a certain level of fluoride concentration, then it's also not effective. And the brushing alone will not reduce the risk of tooth decay. Next slide. So and what is the cost then for prevention? In high-income countries, one would sometimes put the cost of comprehensive care is up to $5,000 per person per year. For prevention, one can pay up to $150 if you have a professional tooth cleaning once a year and fluoride application. But if you just go for self-care, that's something between 30 cents and $5 for toothbrush and toothpaste per year, depending on where you are and what the price for the materials is, but that's what you need. Next slide. So that's quite affordable. And what is important now, I will just introduce a stepwise model for an oral healthcare program. So the very first level is just for children, or is supervised daily toothbrushing with fluoride toothpaste. The next level is, next slide please, or next click, yeah, is additional periodic self-application of a fluoride gel or a fluoride rinsing, which can be done for a high-risk population, but this is still a self-application. Next slide. Next click. So the next click is additional periodic fluoridation through professionals, or also the application of sealants. And the next, please. This is all should be accompanied, as we said before, by an on-demand pain relief and emergency care. Next slide. Which means person should have access to oral, to pain relief and or oral urgent treatment as it's called, and only the number 4 is clinical oral care. For example, in the school setting, this is the last option. This is also very expensive. Next slide, or next click, please. The clicks, you can put the clicks, yeah. So what means is, from step 1 to step 4, you increase the complexity and increase the resources needed. And on the other hand, from 4 back to 1, the number of children will again also go down. So you need the number of children you reach will be many with respect to toothbrushing, but if you want to treat them all, you will be only able to treat very, very few children. That's a system where you can see the increase of complexity will have the price, but you can only reach a few. Next slide. Then I'm nearly through. Again, this is the more full setting, saying that this is a comprehensive model, saying that the most basic thing is the basic toothbrushing, the daily toothbrushing with fluoride toothpaste. This is something you have habit formation, and that is a reinforcement for habit, and that is something to be done every day. You don't need a healthcare setting for that. That can be, for example, in the school setting. and in the home setting, but also in the school setting. In the school setting, there could be additional periodic self-application of fluoride. And you could also, if you have more resources, you could offer also additional periodic fluoridation as or a varnish. But for example, or a screening for children with higher risk, that again takes a lot of resources. And then only for a few you would have the possibility of full clinical oral care. It would be good if the school setting could always bring in an on-demand treatment, but very important also that is some sector while the school setting could work without professionals. And all what you see on the left side in the orange is to be done without health professionals. You would, within the area of screening, you might have people working at the interface, or people could ask who is having pain. That can be a teacher, and he can then refer to the health setting, or somebody from the healthcare setting would come to the school and examine. But that takes a lot of resources again. So this is just to see what kind of interface. So there is a pure phase which can be done in the school without dentists and without healthcare professionals, and then there is a part where healthcare professionals play a role, but of course you have few healthcare professionals, very few dentists, so it's very difficult if you have high burden of disease to provide appropriate care, and that would most probably in the first place be an on-demand pain relief. Next slide. Yeah, just what is the benefit of such a framework? Very clear that such a framework could clearly see that they're reaching more children with basic intervention rather than few with very comprehensive care for a priority and evidence-based resources available. So we can highly say discouraging mass screening and health education because that is not improving the situation. And that's very clear. With such a framework, one could define the roles and responsibilities for teachers and healthcare professionals, which is very important to see that you work effective with each other. And I will stop here, and Denise will bring in a few slides on the Fit for School program. First, thank you, and maybe there are very few questions. I see that I went over the time.
Oh, no worries. I've written down a few questions. So we can discuss them later in the discussion. Yeah. So I will continue from here. Yes, thank you. So the second part is on oral health promotion opportunities in schools. Next slide. So as Bella already stressed out, is the most important thing for effective prevention of oral diseases is to ensure the use of fluorides, particularly to ensure that people are brushing with fluoride toothpaste. And there are several interventions that we have a wealth of information on that are not effective. So for instance, we do know that providing health education to people, explaining them about toothbrushing is not effective on the long term. It will increase people's knowledge, but it will not change their behavior for the long term. You can also see that in the first picture where people are giving health education to children in schools. There is not a supportive environment for children, there is no water, so this is not going to be effective on the long term. And also providing health education via written materials, for instance, leaflets or posters, we know that on the long term that's not effective. Other options, of course, Bella already discussed them, are more treatment, so fluoride varnish, or maybe even treating dental caries with ART or restorations. Of course, it can work, but you can only reach a very small number of children. It's highly costly, and therefore it's not effective on a population level. Next slide. So schools are, of course, excellent venues to promote oral health. What the Ottawa Charter stated in 1986 is that health is created and lived by people within the settings of their everyday life, where they learn, work, play, and love. And we know, of course, that the school is a setting where children spend a lot of their time when they're young. So there are good opportunities for the school to promote health and also oral health. Next slide. So the opportunities for school oral health promotion are, of course, that you reach children at a young age, so then they're still receptive for behavior change. And schools are organized settings, so they work via routines, so that helps also with the development of healthy habits. And if you can create a healthy environment in schools and you can develop skills that are healthy for you, you have lifelong benefits from them. And we know that those interventions in schools can be cost effective. And very important, but we come to that also later at the end, is that oral health promotion ideally is integrated in broader school health promotion programs or water sanitation and hygiene programs. So it should not be an isolated intervention where we only focus on oral health, but oral health could be very well integrated into broader school health and water sanitation and hygiene programs. Next slide. So one of the things we could do to improve daily toothbrushing with fluoride toothpaste is a skill-based approach. So instead of educating people that they should brush their teeth, we could just do it by implementing it daily in schools as a group activity. And then children are learning by doing and hopefully creating a habit. And this was one of the interventions of the Fit for School program that Bella was she was there also at the start when this program was developed. And for those of you who don't know the Fit for School program, I'm going to explain it in the next slide, please. So the Fit for School program is a school health program and also a water sanitation and hygiene program, which focuses on improving the school environment, making it a healthy environment for children, and to develop healthy habits or healthy routines. And it's based on simple interventions consisting of daily group hand washing with soap and also daily toothbrushing with fluoride toothpaste, biannual deworming, so that's now also part of for some countries part of the national program, but every half year children get a deworming tablet. All of these three interventions are evidence-based. And most important maybe is also improving the school environment by providing access to water sanitation and hygiene. Of course, you need access to water in order to be able to wash your hands and to brush your teeth. And what is important to note is also is that ideally this daily group hand washing with soap is done prior to eating. Next slide. So the Fit for School approach originated in the Philippines in 2007-2008, and it was implemented by the Department of Education as the Essential Healthcare Package, Essential Healthcare Program. And in 2011, the Deutsche Gesellschaft für internationale Zusammenarbeit, so GIZ, and the Southeast Asian Ministers of Education CMO in partnered to also expand the FIT approach to Cambodia, Indonesia, and Laos PDR, where it's currently also implemented. Next slide. So here we have a video where we briefly show the Fit for School interventions, and hopefully it's working because it's a nice way to see what Fit for School entails. Just waiting if, no.
Sorry, everyone. The video, we don't have the bandwidth to get videos to work very well, so unfortunately we won't be able to get this to show.
Oh, okay, no problem then. No problem. It's just the video is showing also the interventions, the hand washing, toothbrushing, and the deworming, and what kind of hand washing facilities can be made. But we can continue with the next slide. Yes, next slide. Maybe it's too big. No, There we go. So the Fit for School program is based on 4 important principles, the 4S system, we say, the simple system thinking. So, what is interventions for health promotion are simple. They could be packaged into so a package of several interventions where you address the main common diseases in a particular area. The reason that they need to be simple is that it's very important that the interventions are implemented using existing structures and resources. So for instance, the school setting is an existing structure, and that you get it integrated in the education sector with some health sector. And because the system, the education sector and the health sector, some low income countries, the interventions also need to be simple. If they are complex, it won't work. And then always there's the importance of scale. So interventions need to be scaled up, meaning that they need to be able to be implemented on a larger regional or national scale. And that can only happen if it's simple, if it's integrated in the broader education or health sector. And you need involvement of everyone within the education sector. So clear roles and responsibilities, and often parents and communities are also involved in the implementation of the program. For example, parents are involved in the construction of group hand washing facilities, and they're also involved in the monitoring of the program. So monitoring whether supplies are available and whether the program is running as planned. So these are all very important elements in order to get a program implemented on a larger scale and also on the longer term. And next slide. So this is showing where the regional Fit for School program is currently implemented. The implementation of the Fit for School program always started with model schools with support of GIZ, the organization in Germany. So you see there were 10 model schools in Cambodia, 22 in Laos, was the model country because that's where it started, and Indonesia started with 12 model schools. And now the countries are scaling it up on their own. So it's not dependent on donors anymore. The countries themselves are scaling it up. And you can see that they're reaching many schools in those 4 countries. Next slide. So just to tell you a little bit about the evidence on the effect of the Fit for School program, because throughout the entire implementation of the FIT program, a lot of research has been conducted to also see whether it works and also see what in order to get it working. And one of the studies that I would like to present is the Fit for School program assessment study. This study looked for the impact of the Fit for School interventions on particularly child health outcomes, so dental caries, underweight, and parasitological infections. But we also looked at changes in behavior and water sanitation and hygiene. And the main aim was to see whether after 2 years of implementation, parasitological, nutritional, and oral health status of children would improve. And next slide. So it was a 2-year study with 41 schools in Cambodia, Indonesia, and Laos PDR who implemented the program, and 41 schools who did not implement the program. And at baseline, prior to implementation, we collected data from 6-7-year-old children, and 2 years later they were followed up. Next slide. So from the children at baseline and 2 years later, we collected data on dental caries, but also on underweight or weight status, and whether they had worms, and we conducted a socio-demographic interview. And that was done by a team of researchers that were trained, local researchers. I'm just going to present the results then on oral health. Thank you. So what we saw in the 3 countries is that on average 94% of the children had dental caries, which is similar to what we saw earlier in the Philippines. And on average they had 9 of 20 teeth affected with dental caries, so half of the teeth had dental caries. And also 73% of children had at least 1 tooth with infection, and the mean number of teeth affected with dental infection was almost 4. So the dental caries severity was very high in these children. And this is about the primary dentition. Next slide. And then we looked at the increase in dental caries over 2 years. So DMFT means the number of decayed, missing and filled teeth in the permanent teeth. So at age 6 at baseline, the permanent teeth were just erupting. And we saw that after 2 years, schools that had the Fit for School intervention had on average 0.5 new teeth with a tooth decay. And in control schools, that was 0.63. And that was statistically different. And then you can calculate how much dental caries was prevented over the 2 years. And the preventive fraction in the countries, of all the countries, was 24, meaning that by the toothbrushing intervention in Fit for School, 24% of dental cavities were prevented. And in the specific countries, it was 18% in Cambodia, 22% in Indonesia, and 38% in Laos. So also differences within countries. Next click. So if we look at the evidence from the literature, they also found that by twice daily toothbrushing with fluoride toothpaste, we can prevent about 24% of dental caries. So this is in line with what the literature found. And it's also very important to notice that you won't reach this with any other methods than with toothbrushing. It's the most effective way to prevent dental caries. And so school-based toothbrushing in school, as daily group brushing in schools, seems an effective way to prevent dental caries, but not all the dental caries yet. Next slide. I need to hurry up a little bit. So what we saw is that there is differences between countries, and what we learned from that is there are probably differences in implementation quality, because if all the countries were similar, if they all implement the program in the same way, we would expect the same effect in all the countries. So an important thing for the future and an important learning is that implementation of the program is very important. So we should have very clear roles and commitment from everybody involved in implementing the program. So that's at government level, but also people, the school heads, the teachers, the parents, everybody needs to have commitment in order for it to work. And we also said that for future program evaluation research, we should also not only look at whether those interventions prevent tooth decay, so health outcomes, whether health outcomes are improved, but we could also look at intermediary outcomes. So it's very important to evaluate whether implementation and monitoring processes are well implemented, and also whether we see behavior change, because that's the first step for caries prevention, and then caries prevention comes later on. And that's what we're currently doing. And next slide. So more findings on the research can be found in this paper, in case you are interested. Next slide. So as Bella already said, there are other potential interventions in addition to daily toothbrushing in group toothbrushing in schools. One of the things you could do is once a week toothbrushing with a higher concentrated fluoride gel. This has been studied in addition to toothbrushing, so it's not an alternative for toothbrushing, but it could be a supplementary intervention. Another important thing that Bella says is access to urgent oral care, or application of silver diamond fluoride or other fluoride varnish, but this requires personal and also there are higher costs attached, and then we come to the same problem where that it's costly and then you won't reach as many people. So next slide is just to remind us on the previous slide that Bella already said, the more complex an intervention becomes, the less people you will be reached because it's costly and it's more resource. You need more resources for it. Next slide. So last slide is a unique opportunity is now that in 2015 the Sustainable Development Goals were launched, and water sanitation and hygiene indicators are now included in the Sustainable Development Goals. So what is mentioned in the Sustainable Development Goals is that all schools should reach basic water sanitation and hygiene services by 2030. That means basic drinking water is important. They should reach basic sanitation, so improved facilities, accessible, functional and private toilets at schools, and very important, basic hand washing. So hand washing becomes a priority for schools, and hand washing or hygiene, oral hygiene can be is part of overall hygiene. So this is something where oral health could be very well integrated. So as Bella always says, oral health could fly under the wings of hand hygiene, and this provides unique opportunities to integrate oral health into water sanitation and hygiene programs that are implemented in schools. Next slide. So in conclusion, oral health interventions should be among priority choices in health promoting planning to improve child development, because as we see, it's a very high burden. A lot of people suffer from it. And we know from evidence that school-based toothbrushing with fluoride toothpaste as a group activity can be an effective method to prevent dental caries. And as we said, oral health interventions should not fly alone. They should be integrated into schools as part of broader school feeding or school health and wash programs. That is the last slide. Thank you very much. And I think we can now go to address questions that you have and have a discussion.
Thank you, Denise, and thank you, Bella, for the excellent presentations and sharing a wealth of knowledge with us on oral health. There have been several questions in the chat screen, and I know that Bella's been answering them as you've been speaking, and likewise in the earlier presentation, you've answered many of the questions. There was one about, what is the recommended number of dentists per population. I'm not sure if that was covered. And then if there are any other questions or comments that you would want to touch on from the discussion we've been having through the webinar.
Well, it's an interesting question, but also a difficult one to answer. I think what we say in Western countries such as Europe, we strive for one dentist over for 2,000, 3,000 people. But it also depends a bit on the oral health needs. So, of course, when we talk about the number of dentists needed, we think about the full set of treatment and prevention that we could provide. And for many countries, that's not feasible. For example, if you only think about oral urgent care, if that is your priority, so extracting teeth if there is infection and pain, then you need a different number of dentists. And of course, when you think about full restorative treatment and preventive treatment, etc. So I don't think we can give an answer to it. But what we can say is that by just increasing the number of dentists in low and middle income countries, we won't solve the problem because it's too expensive, the burden is too high. So we should really focus on prevention, and prevention does not always need to be given by dental professionals. It's mainly self-care. So I think that's where the focus should lie.
Thank you, Denise. And another question just related to, daily toothbrushing and the promotion as part of a school wash intervention. Have you had experience in promoting daily toothbrushing alongside other nutrition promoting interventions in schools? So, you know, yeah.
Yeah, perhaps briefly, yes. We have, in some countries, we have in autonomous region, for example, we have hygiene programs going with feeding programs. So you have a feeding program. Prior to feeding, you wash your hands, and after feeding, they brush their teeth. So that fits nicely together. So that is something that could go very, very well together. So it's also in the Philippines now at a point where at least the Philippine Department of Education pays for all children who are receiving a school feeding, those who are malnourished. They receive also toothpaste in the school, but it's not, that's also at least something which is already, resources have been made available for all kids receiving this feeding meal. So, and the Philippines is now also in the process of providing toothpaste for the entire school year as resources of the Department of Education for all kids from grade 1 to grade 4, or kinder to grade 4, even kindergarten. Yeah, that is new coming in now. So I hope it will really be rolled out more and more.
Excellent. And just in terms of, national policies, local policies on oral health promotion, and we've seen this in South and Southeast Asia where ministries of health, departments of health are still promoting the screening as a first intervention, not really going through that stepwise approach. What would your recommendation be in terms of, looking at what's already there? In some places, you would even see a school nurse and, providing certain services, a dental chair. So what would your recommendation be in terms of, now incrementally improving on that?
Yeah, I know that it's always a big battle when the limited resources are being used for screening. Because what is the purpose? They will screen all the kids. It takes a lot of time, and then there is no access to treatment. It would be much, because and then where to send them? Yeah, so that they all have tooth decay, or many of them have tooth decay is a known fact. They know it by themselves. They know that they're suffering pain. They don't need this information that they have tooth decay. They know it. And I think it's even up to the point of being unethical to screen for something but not providing and referring to treatment. And I have seen that all over. I've seen these really thousands of kids here in the Philippines, no access to treatment. None of them has ever been treated. So it's a big problem, but people still feel, and dentists still feel, that the first thing they have to do is to screen. So this is just first countries around the globe. The UK is not doing it anymore, and more countries starting not to do screening anymore. I think there's a very interesting question here coming from Benoit. Best strategy to improve the affordability of fluoride toothpaste in low and middle income countries. Yeah, that is a very difficult question. I think the first thing might be something to really get in contact with the companies. Many companies offer little sachets for schools. Colgate is doing that in many countries. But I think it would be the best to really sit with the companies and discuss that they make it available for schools for a lower price, or for ministries of education for a lower price, or for ministries of health. So providing special prices for the government so that it can be really widespread used. Other possibilities is it's really, I think that can only be done together. Tax reduction might be one point to us to work on. Tax reduction might be a possibility, or really looking for supporting local production. That is also perhaps a possibility. But maybe sitting with the multinationals, and discussing options for reducing the price. When it's used in, for example, in government institutions like schools or daycare centers, and it can be packaged separately so that it will not land in the household of the teachers and the school heads. Yeah, we have done costing around toothpaste, how much should it be for daily toothbrushing. If you brush your teeth, the amount you need is around 0.3 grams of toothpaste. So if you have 200 days of school, you would need 60 milliliters or 0.3 ml. You would need 60 ml of toothpaste for an school year. That's what you need per child with respect to toothpaste plus a toothbrush. This is available for a price starting at $50 and maybe goes up to one, or but you can get it for $50. Toothbrush and toothpaste for an entail for every day in the school. That's possible. What is the question? 0.3 milliliter per child per day. Yeah. So you have 200 days, so you need 60 ml.
Great, excellent. Thank you so much, Bella. And thank you to both our presenters and all our participants for joining in this webinar today. We're actually left with only a couple more minutes before we come to the end of the hour. But before I announce the webinar for you, are there any other questions? If anyone would like to unmute and ask a question or type in. Or Bella or Denise, if you have any parting words of wisdom.
I see a question here. What are our views on the growing interest on sugar beverage taxation? That's another question, and an interesting one also, of course.
Yeah, I like it.
Yeah,
I like it because I like it. We have it in the Philippines now. I really, really like it. I think there was WHO support and a lot of movement for that. It was well taken up by the Department of Health. I think they really took it on board. I don't know how long it will take that really people will drink less or that it has an impact. I'm not so sure. But what will be an impact for sure is that people realize that something's wrong with sugar-sweetened beverages. So at least they might get into a negative corner, so people at least start to think about it. I think that's something which at least I can see already within the Department of Education. So there's also a ban of sugar-sweetened beverages in schools now. But that will still take time, that it really, the people connect the dots. For example, with meetings within the Department of Education, they will still serve sugar-sweetened beverages. So sometimes it takes time that people really, that behavior and also an awareness is getting, really sinks in. But people start talking about it, and I think there will be a change. But it will not come overnight. There's always a lot of work behind that. But I think it's a very excellent idea to do that. You can also see it in the reaction of the industry. They don't like it at all, and they're really getting furious about it. That means it will have an impact.
Yeah, I agree with that. Also, what you said, Bella, the banning of sugary drinks at schools is also a very important thing. In addition to that, but I agree with you. It's a positive change.